Good afternoon, everybody. We're going to kick off the next session on Alzheimer's. And before we do, I just quickly want to thank everybody and thank everybody out there that's tuning in. You know, this program, a few years back, we started to broadcast it, and it just shows the need and the breadth of the information that these physicians outline in the great minds of Mass General and Brigham Women's and Cedars-Sinai. But just quickly to let everybody know that's listening and that's out there, 5 countries, 16 states, and 137 towns and cities signed up for this program. So again, it just shows the need for programs like this. And if it wasn't for our partners, we wouldn't be able to pull it off. So just a couple of shout outs to our major sponsors, Leader Bank, InfoCare RX, Novartis, and obviously our very good friends at Biogen. So thank you all for allowing us to have this educational update in our Neurological Symposium. And with that, I'd like to give the forum now to the doctors, and thank you very much for all you do.
Yeah, good afternoon. Can you hear me well? Yeah, great. So hi, my name is Valentina Perosa. I am an assistant professor at the MGH in Boston, and I would like to thank the McCourt Foundation for inviting me and also for sponsoring part of my research. And today I would like to talk about something that I very much care about, which is a little bit of prevention of dementia and Alzheimer's disease. So maybe let's start a little bit with a definition. First and foremost, so what is dementia? Dementia is a clinical syndrome characterized by a decline in one or more cognitive domains that also really impairs the everyday life and experience of the patient and represents a decline compared to the previous state in functioning. And I'm sure when one talks about dementia, most of us think about Alzheimer's dementia, which is kind of clear because it's the most common form of dementia. And the first person who looked inside a brain and defined this pathology was Alois Alzheimer. He treated a patient called Auguste Dieter in 1901. And then after she died, he took care of the autopsy of the brain and found that inside of her brain, he could see this pathology, especially the amyloid beta plaques, which you can see at the bottom left of the slide. So that was the first pathology that was identified within a brain with Alzheimer's disease. And then over the years, of course, the researchers found several other pathologies, such as tau tangles, which accumulate like inside of the neurons, but also related pathologies such as phospho-TDP43 and alpha-synuclein. So, and I don't want to turn this into an epidemiology lecture, but just to give you some figures, in the US, we have 6.9 million patients with Alzheimer's disease. So these were figures that were published in the journal Alzheimer's Dementia last year. And we know that, projecting these figures, we know that by 2060, we will have about 14 million people with Alzheimer's living in this country. And of course, this is a burden for the patient, but it's also a burden for everyone, for the families, for the caregivers. In fact, 60% of caregivers reported a very high amount of stress. And furthermore, we have the economical cost of the disease, which is $360 billion, which is also very high. So wouldn't it be nice if Alzheimer's and dementia was partially preventable? And well, it turns out that it actually is partially preventable, or at least this is what a commission of the journal Lancet reported. They analyzed many studies with big meta-analysis, big clinical studies, and identified some factors that actually help preventing part of Alzheimer's disease and dementia. One in early life is education, but then in late life we also find the social isolation, air pollution, and visual loss, which are risk factors for the disease. But today I would like to focus especially on the midlife risk factors. So we have many of those, and they account for a great percentage of the risk of Alzheimer's and dementia. So maybe about these factors, there are some that are quite surprising. I believe to many of us, one of those is hearing loss, that accounts for 7% of the risk of Alzheimer's disease and dementia. And we know that actually trying to compensate hearing loss, for instance, using hearing aids, has been reported to be beneficial in preventing cognitive decline. Another one, oh sorry, this was later. But another one which is also important is traumatic brain injury. So this is something that happens especially during fights and falls, but there are also sports that can cause traumatic brain injury, such as American football, boxing, and even soccer. And this traumatic brain injuries can provoke a kind of pathology that is similar in some ways to that that we see in Alzheimer's disease. Another one which may be a bit surprising is depression. So that accounts for also some risk in dementia, especially if it's during midlife or long life depression, and even treating this disease can be beneficial for preventing cognitive decline later on in life. And then we have hypertension. So this has been shown in many studies that really treating hypertension even relatively aggressively could have benefits towards improving later cognitive decline. And of course, smoking and alcohol, we all know these are not the best habits that we can take. Smoking was dangerous for dementia at all life stages, but also it was seen that quitting smoking at any time point during life would have a benefit later on. And alcohol there is a little bit more tricky because we don't really know whether it's only very heavy alcohol consumption that leads to cognitive decline, or if it's also moderate and mild alcohol consumption that does that to a patient, but definitely also an important factor. And then something which may be surprising to some of you is also elevated LDL cholesterol that has been shown to account for about 7% of the risk of dementia, and that's a relatively new finding and observation that we have seen actually in the last Lancet Commission. And then we have diabetes, and physical inactivity is also a risk factor, and obesity per se. So even if we account for all the related pathologies that can come with obesity, obesity in itself is a risk factor for dementia and cognitive decline. And then there are some that didn't really quite make the cut for this commission, such as a poor sleep and processed foods or high-fat diet. But there is still a lot of evidence out there that actually points towards that direction. So I wouldn't be surprised if in 4 years, with the next study, when there are more meta-analysis, we may see how this also make the cut for prevention of the disease. And there are some clinical trials that have already been conducted which tried to apply this knowledge in preventing Alzheimer's disease and dementia. And we saw, for example, in the Sprint Mind trial, they tried to really aggressively treat elevated blood pressure, and we couldn't see really quite a significant effect on dementia, but it definitely had an effect on mild cognitive impairment. And I think one of the studies that, in my opinion, is most interesting is the FINGER trial, which stands for Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. So in this trial, they actually use a multifactorial approach and included about 1,260 participants between the age of 60 and 77. And these participants were then randomized into two different arms of the trial. So it was a double-blind, randomized control trial. And the intervention group got a bunch of interventions. They were monitored to have a healthy diet. They also were included in physical activity sessions for at least 2 times a week. They received mental stimulation, and also their cardiovascular factors were constantly checked and re-equilibrated, let's say, and treated. And finally, they also had more social interaction than the other arm of the study, because through the process of the study in itself, of course, they got to interact with other participants multiple times a week. And what they saw after 2 years of this intervention was that overall cognition improved by 25%. And then there was an even stronger improvement in other cognitive functions, in specific cognitive functions. But they also saw that there was a reduction in multimorbidity by 60%, meaning that the patients got less sick overall, also in other, considering other illnesses. And finally, a model showed that actually applying these interventions would be cost-effective also on a larger scale if this was done successfully, which is, in my opinion, very interesting aspect. So when we look at all these factors that I just mentioned, I think it's very interesting that many of those are the same cardiovascular risk factors that are also suggested by the American Heart Association in order to prevent cardiovascular disease, so heart attacks and the stroke as well. So many of those overlap with them. And this kind of points towards an important aspect of dementia and Alzheimer's disease, which is the health of the brain vessels. And in fact, if we go back to the pathology, we don't only see all these proteinopathies, so these protein accumulations that I mentioned before, but we also see a lot of vascular disease. So on the right, you can see one which is a cerebral amyloid angiopathy, which is my main area of study. And that represents basically the accumulation of amyloid beta in the vessels of the cortex, so of the gray matter, and also on the leptomeningeal vessels, which are vessels that are basically on top of the brain. And we also see a lot of arteriolosclerosis, which is this thickening and loss of structure of the small vessels in the brain. And yeah, just I need to make a little historical digression again here. So CAA, or cerebral amyloid angiopathy, is actually a pathology that is not new at all. This has been already investigated, or had been investigated by Gaetano Perusini, who was an assistant of Alois Alzheimer. So they saw this in the first patients already. And I always mention this because it's kind of funny. I found out about him only 2 years ago, but he also comes from my hometown, which is Udine in Italy. So this was a funny coincidence. Unfortunately, the man died in World War I, and this line of research was abandoned for quite a long time. So it's actually not very surprising that brain vessels are so important for the development of dementia as well, because the brain is a very highly metabolically demanding organ. It has only 2% of the body weight. The brain only represents 2% of the body weight, but it actually pulls to itself about 15 to 20% of the cardiac output. So 15 to 20% of the blood goes to the brain every time that your heart beats. And in fact, the brain is also highly vascularized, meaning there is a lot of brain vessels. I'm sorry, just going back a second. And these brain vessels are not the average brain vessels, so they have a lot of functions. They, of course, nourish brain cells, provide nourishment and oxygen, but also they regulate the blood flow. They have a role in immune surveillance, and they have apparently a role also in waste removal of toxic proteins from the brain. So what we do in my lab is that we try to investigate these interactions between vessels and the rest of the pathologies that we find in Alzheimer's disease and in vascular dementia through in vivo MRI, ex vivo MRI, meaning after a patient dies, and then finally using histopathology as well. So for what this means, for example, is in this case, for example, we had one patient that was recruited by our studies during life. This patient had cerebral amyloid angiopathy, which was already diagnosed during life. But we saw then this tiny microbleeds. So these are tiny bleeds that we observed in the brain. And then after they passed, the family and the patient themselves, they decided to donate part of the brain, or their brain, to us so that we could look further into it. And what we did was to take one hemisphere and scan it at a higher resolution on MRI. And then we also cut this brain and identified a slab in which there were even more of these little bleeds than we could see during life, and scanned it at even higher resolution using 7 Tesla MRI, so that there were even more microbleeds. And then finally, we took a piece of these little pieces of the brain, embedded them in paraffin, and cut the serial sections and colored them for several markers. And in this case, for example, what we observed was that the vascular pathology that we thought would provoke this little bleeds was in fact not what we expected. It was arterial sclerosis instead of a CAA. So it's a useful approach that can be also translational. And another work that we do in the lab is to use AI in order to quantify histological markers of disease. So this is useful because we can be more objective in saying how much of a specific marker is in a certain section, and we can also have a quantitative and continuous measure that allows us to produce a little bit more reliable statistical models to investigate these interactions. And we did this also in a cohort, in an autopsy cohort of patients with Alzheimer's disease. We took 152 cases from the Massachusetts Alzheimer's Disease Research Center, and we investigated an area of the brain, which is the medial temporal lobe, which I'm sure many of you have heard of. That's where the hippocampus and the entorhinal cortex are. And these are very important brain areas because first of all, they are fundamental for global cognition and also for memory, but they are also the brain areas in which Alzheimer's disease pathology accumulates quite early on in the course of the disease. So we have, of course, tau and tau tangles, the amyloid beta plaques, so they come a little bit later, but also phospho-TDP-43, and we see CAA and arterial sclerosis as well. And what we found here, what we found here was that, for example, this CAA, so cerebral amyloid angiopathy, was directly related to the quantity of tau tangles and amyloid beta plaques in this area of the brain. So there was a direct association between the two, meaning that the vascular pathology likely also influences the non-vascular pathology that we see in Alzheimer's disease. And we also went a little step further. So we took one of these brain blocks and scanned it at using a microcomputed tomography. So this has a resolution of 11 micrometer, And this allowed us to follow each single vessel, or most of them at least, and investigate how the pathology in a specific section of the vessel could potentially be related to the downstream part of the vessel and the pathology surrounding it. And this was possible because the three-dimensional image that we had, thanks to the micro-CT, was taken exactly on the same block that was then cut and produced serial sections that were then stained for several markers and aligned to the three-dimensional image. And of course, we're by far not the first one to show that there is a contribution of cerebral vessel disease to Alzheimer's disease. There are many studies out there that looked at this aspect from an epidemiological perspective, from also like a therapeutic perspective and pathological and animal studies. So there is a lot out there. But one aspect that is particularly interesting to us is how does it work? Like, why are the vessels potentially so important? And of course, all of these functions that the vessels accomplish could be a potential answer. But one that we found very interesting is the waste removal, also called brain clearance. So it seems like the vessels play a role in this process. And we think in our lab that there's still quite a bit of controversy on how this process really works. But what we think is happening is that the waste is transported out of the brain alongside from the vessels in a space that is called the perivascular space. So if you see in this image, you can see in red the blood vessel penetrating the brain, and it's surrounded by this blue space, which is the perivascular space, that it's fluid filled. So we think that potentially the waste is collected and then transported out of the brain through this space. And this is just another representation, like a little graphic that a friend of mine did. So you can see in brown the waste, and that is produced in the parenchyma, and you can see how it potentially is transported out of the brain thanks to also the pulsations of the vessel itself. But then we have to wonder, of course, what happens if these vessels are non-functional anymore, maybe because there is a CAA, so this amyloid beta accumulation in the vessel walls, or arteriolosclerosis, which was this thickening of the vessel wall that I mentioned before. Then probably the vessel become more stiff and they're not really able to perform their function as well. So what we think is happening is that then there is a blockade in the transport of the waste out of the brain. And so this would look like that in a cross-sectional animation, and this is possibly the result, or at least part of the reasons why we see amyloid beta plaques and cerebral amyloid angiopathy in the brain. So this is, of course, not it's not completely certain by far, because there is still a lot of unanswered questions, and most of these processes are hard to really prove in the human brain, because the structures are so small and the functional imaging is not there yet to really prove it in people, but there are a lot of animal studies that point towards that direction. What we also think is potentially happening is that when the waste accumulates in a certain part of the vessel, that some of the fluid remains stuck inside of the brain or inside of the perivascular space, and that the perivascular spaces could enlarge downstream of it. And this is why we decided to also study these perivascular spaces, and what we could see was that there was an association between the degree of enlargement of the perivascular spaces in pathology and also in MRI, and the amount of cerebral amyloid angiopathy in the same brains, in the same sections, And we saw the same also for arteriolosclerosis, also for the other kind of small vessel disease that I've mentioned before. And we also observed the same in the previous studies that I've mentioned that we have conducted on the medial temporal lobe of cases with Alzheimer's disease. We saw the same association as well. So we also decided to really look a little bit more three-dimensionally at this perivascular spaces, and we took another piece of brain, this time from a patient with a cerebral amyloid angiopathy, and this was scan at a 7 Tesla MRI at high resolution, and you can see in white how this perivascular spaces, I'm not sure if I have. You can see in white the perivascular spaces that enlarge in the white matter, and sometimes you can also follow this black vessels that go from the cortex then down into the white matter, and to see how the space is really enlarged around the same perforating arteries. Yeah, so this was it, and I hope I could convince you today that each of us can actually do quite a lot to prevent dementia, and that it's crucial to implement public health strategies for prevention as well, and that it's also important for all of us to keep our brain vessels healthy, and that we should continue to better understand brain clearance, because there are potential, maybe therapeutic strategies that can target that aspect as well. I would like to thank you for your attention. Thank you, my lab and my mentor, Suzanne, and of course the McCourt Foundation for inviting me and founding part of my research. Thank you.
So we'll move on to the next presentation that I'll give. My name is John Dickson. I'm a neurologist at Mass General, and I also oversee as a co-director of the anti-amyloid program at Mass General called the Alzheimer Therapeutics Program. And today I'm going to be talking about some of the work that we've been doing using real-world data from our clinical experience in this Alzheimer Therapeutics Program with relation to these new drugs that have come out to treat Alzheimer's disease, which fall broadly into the category of anti-amyloid therapy. And as we get started, I just wanted to mention that I don't have any relevant financial conflicts of interest related to any of these treatments. I have served on a scientific advisory board for a pharmaceutical company in the past, but it's unrelated to these medicines. So to give a little bit of background about Alzheimer's disease, most of you, if not all of you, are familiar with it to some degree because it is so common. Almost everyone knows someone who has had Alzheimer's disease. It's a memory disorder, usually that presents with memory loss, short-term memory loss in particular. And it's a progressive disease that leads ultimately to people losing their ability to do activities of everyday living that can include things like managing finances, remembering to take medications, and then eventually having difficulty with even basic personal care like brushing teeth, combing hair, bathing, those types of things. As I mentioned, it is a very common illness, and it's also the 6th most common cause of death in the United States currently. When we look at the brain of patients who have Alzheimer's disease, there are two main findings, and Dr. Perosa kind of demonstrated these as well in her presentation. But you can see that when you look at the brain, these brown areas are areas that are stained for a protein called amyloid beta. And that's one of the two proteins that accumulates in Alzheimer's disease brains. The other is a protein called tau that also looks brown in this staining. And these two together make the hallmarks for Alzheimer's disease. To give a little bit of an understanding of why we're particularly interested in targeting the amyloid beta with the drugs that I'm going to be talking about, one important thing to recognize about these is that the proteins are in different places. For amyloid beta, these are actually outside of the cells in the brain, like neurons, whereas tau is inside the neurons. So you can see these brown areas are inside of the nerve cells. And since the amyloid beta is outside the nerve cells, it's easier for the treatment, which is an antibody, to have access to that. And that's one of the reasons that anti-amyloid therapy is probably the first treatment that is coming available to help modify the disease process. There are other reasons that we would want to target amyloid. In particular, there are some rare genetic mutations that cause Alzheimer's disease in certain families, and those families have mutations in proteins that are involved in generating the amyloid beta protein that accumulates. The discovery that we have of these mutations, as well as the other research that's been done, including the work related to the pathological findings, has led to the development of what's called the amyloid cascade hypothesis, and that's what's shown over on the right side of the screen here. And you can see that in this process, amyloid gets disrupted early on, and then it leads to further problems like the deposition of the tau protein, dysfunction of the nerve cells, and then ultimately the death of the nerve cells, which leads to the clinical symptoms of dementia. So the idea behind these therapies is that we want to target kind of early on in the process so that we can prevent the further steps happening along this pathway. So the two drugs that are particularly relevant for this presentation are called lecanemab and donanemab. Both of them are antibodies that are delivered to the body through an IV infusion. So an IV is placed and the medication is infused over a period of time into patients, where then it goes throughout the body, but especially to the brain. And what happens for both of these is that these antibodies target the amyloid proteins that are present inside the brain, and it helps the immune system clear those proteins, and ultimately it can lead to a removal of the amyloid. And this is something that we can see on imaging, such as an amyloid PET, in patients who are treated with these drugs. These drugs have both been studied in clinical trials, including phase 3 clinical trials, which are sort of the largest types of clinical trials we have. And these are some of the results that are from those two clinical trials for these medicines. There's a lot of detail here, which we won't go into, but the main things that I want to point out is that you can see for both lecanemab and donanemab, there's a continued progression of disease. So regardless of whether people have treatment or not, there is a continued decline in cognitive function. But in both cases, the treatment with the drug slows the progression of disease. And at the end of the 18-month trial, that's right around 30% of slowing. And if you translate that into months over the 18-month trial, that's about 5 to 6 months of slowing over the course of that clinical trial. So this is the effect that we're trying to achieve when we treat patients, is the slowing of disease progression with cognitive decline. There are some side effects to all medicines, and in the case of both of these drugs, one of the side effects is an infusion-related reaction. This is something that happens during or shortly after an infusion is given, and it's kind of like a body's reaction to the drug being put in, which is an antibody. Sometimes people can have an immune reaction to that. There are several symptoms that people can have, which are listed here, and to kind of put it in broad strokes, some of them can be more of like a cold and flu-like reaction with fever, chills, shakiness, muscle or joint aches. And then the other type is more of an allergic reaction, where people can have changes in blood pressure, difficulty breathing, rashes, and those types of things. It's much more common to have the cold and flu type of reaction. They tend to be relatively time limited and can be treated with symptomatic medications in most cases. You can see that the two drugs have slightly different rates of infusion-related reactions, with lecanemab having more than donanemab. The other side effect that these medications generally have is something called amyloid-related imaging abnormalities, and this is the thing that people really worry about. This is generally changes that we see on the MRI, And there are two subtypes of it. One is called ARIA-E, and that E stands for edema or effusion, and that's where there's swelling in the brain. Sometimes the swelling can happen outside or inside the brain. So you can see here this white area, as well as down here. That's areas of swelling that are happening inside the brain where there's increased fluid accumulation that causes swelling. That can also happen outside the brain, and in this case, the white area is kind of flowing along the curves of the brain, meaning that it's on the outside of the brain, just sitting on top of the brain. That's also an area of swelling, but it's in a different location. Both of those are considered ARIA-E. Another type is called ARIA-H. That H is for hemosiderin, which is a type of iron deposition or hemorrhage. And this is where there's bleeding inside or outside of the brain. And you can see some examples here. It may be a little hard to see because they're tiny, but there are some small areas of bleeding inside the brain. In this particular case, they're called microhemorrhages because they're essentially microscopic areas of bleeding. And then when it's outside the brain, it's called superficial siderosis. That means that the iron is seen from the blood products on the surface of the brain, kind of going along the folds. These are kind of the most concerning symptoms for these medicines, and they can have a wide range of symptoms. Sometimes they're not causing any symptoms. In fact, the most common thing is that these don't cause any symptoms to patients, and the only way that we know it is that they are present on the MRI when we check. But there can be a whole range of neurological symptoms that can develop as a result of ARIA, and in a few, thankfully rare cases, there can be even serious symptoms that lead ultimately to a patient's death. So that's what we're trying to be careful to avoid as we're taking care of these patients. So what I'm going to be talking about is the kind of real world data that we have on these, not in a clinical trial, but what's happening in actual clinical practice. And it's important to think about this because these medicines represent a shift in the way that we think about Alzheimer's disease diagnosis and treatment, as well as how we're delivering care to patients with Alzheimer's disease now. And I kind of highlighted some of the big changes that this type of therapy has brought to us. So for example, we used to not use biomarkers for Alzheimer's disease like scans or fluid biomarkers that let us know that the disease is present. Some people would have that testing before these medicines came along, but it was not required, and most people didn't want to go through the hassle of having a spinal tap or an extra brain scan. Now it's mandatory to have this because we need to make sure that the amyloid is present so that we'll know that there's a reason to take it away. The treatment focus has also changed. Previously, the focus of the treatment was on symptomatic treatment with pills or patches, and those would help to treat the symptoms of memory loss, but they weren't changing the underlying problem happening in the brain. Now, these drugs are considered disease modifying, where they change the actual disease process that's happening inside the brain. The treatment setting has changed. So before these drugs came out, we would write a prescription, people would pick it up at their pharmacy, they would take the pills or use the patches at home. Now we're having to use an infusion center, which is attached to a medical center of some sort to provide these infusions. There can be some instances where people can have home infusions, but for the most part, things are taking place in an infusion center. And then side effect risk is another important consideration. The previous medicines generally had a relatively low side effect profile, and with anti-amyloid therapy, there is the concern about the ARIA side effects that requires more kind of monitoring for patients. And that it takes the form of periodic MRIs, so there has to be coordination between MRIs and infusions. This complexity is much more difficult to manage at a single doctor level than it used to be because we didn't previously have to, make sure things were happening at the infusion center, make sure things were happening at the MRI suite. Now, there's a lot more that we have to do that requires hands-on activity. And to address that, at Mass General Brigham, we created a special treatment program called the Alzheimer Therapeutics Program that would allow us to address the changes that these new therapies brought to clinical practice so that we could safely deliver these medicines to our patients. This is kind of an overview of what the initial induction into the treatment program is like. There is a referral order that doctors can place in the medical record system that would then alert our team that that patient has been referred. There are some very general triage requirements to make sure that people don't have a clear reason in their medical record that they couldn't take these medicines. For example, if they were on a blood thinner that might increase the risk for bleeding. If there is something that's identified, then we would let the person who referred them know they're not a candidate for this therapy. You should think about other options, including research participation. If patients aren't making it past that initial triage stage, they come to the specialized clinic that we have in the ATP for evaluation to help determine if they're eligible. The reason that we make this determination about eligibility is that we're trying to make sure that the patients we are treating are likely to receive the benefits of it based on the way the clinical trials were designed, and try to minimize the risk for harms due to the ARIA side effects. If a patient is found to be eligible, then the drug is ordered, and that ultimately triggers the infusion center to start the scheduling and begin the infusions. So we wanted to understand kind of what the implications were of this therapy because it is quite new to our clinical practice. And so we set out to understand the initial experience we had in the Alzheimer therapeutics program. And we had a few goals for doing this initial look. One is we wanted to see what happened to the people who were referred, what decisions were made about them, and how many people were in those different groups of those who were found to be eligible, those who were, went on to receive treatment, those who were found to be ineligible. We also wanted to see what the characteristics were like for patients who were found to be eligible versus those who were ineligible. And then also to look into the rates of side effects and to think about how those compare to what we know about from the phase 3 clinical trials. So the way that we did this is we used the patient records of patients in this treatment program, and we looked back to see the details of what happened to them after they were referred, if they decided to continue with, to go on with treatment, if they received any infusions, if they had any side effects. And we did this during the first year of the program operation. That was from September 1st of 2023 to August 31st of 2024. There were a few referrals that were put in error. They were, to be assessed for some condition that was unrelated to this. It just means the person who put the referral in accidentally ordered the wrong thing. And in that group of patients who were all referred during the first year of treatment, we followed them through May 31st of this year, and we wanted to have that time gap between the last referral and when we looked so that we would be able to give them time to go through the process of evaluation, being treated, and having treatments for enough of a period of time that we would be able to tell if they had side effects. So this is what we found in terms of what happened with the referrals. Over the first year of the program across Mass General and Brigham and Women's Hospital, we had 544 unique referrals. 5 of those were placed on accident, leaving us with 539 patients who were referred specifically for the treatment with these drugs. There were about 14% that were triaged out of the clinic before they were seen based off of something in their chart that let us know that they would not be eligible. The remaining were seen in the clinic for an initial evaluation, and you can see that about 20% of the original population was found to be ineligible once they were seen in the ATB clinic, and about 66% were found to be eligible. Among those who were eligible, some of them decided that they did not want to receive therapy after they learned more about it. Some did not receive treatment even though we had planned for that. It's a little unclear why that is because we didn't have further visits from them. And then about 55% had at least one infusion, 55% of the original set of referrals. The vast majority of these were with a medication called lecanemab, And there were a couple with donanemab. That has to do with the fact that lecanemab came out first. We also looked at reasons that people were found to be ineligible. And this is the list of all the reasons that people were found to be ineligible upon evaluation. You can see that the top is what we call a loss to follow-up, which is where people did not come back for a required clinic visit. It's hard to know, since they didn't come to clinic, what exactly the reason was, but you might imagine that some of them decided not to go through with treatment, so they decided not to come back. We don't really know exactly. There are requirements for cognitive testing to make sure that people meet the criteria that was used in the clinical trials, and 18 patients were not eligible because they had cognitive testing that was too low to be considered eligible. Moderate stage dementia is a similar thing. These drugs are approved for mild cognitive impairment or mild dementia, not for moderate or severe dementia. Some patients didn't complete the testing that was required. There were some that were using anticoagulants that increased the risk for bleeding. And then there were other risk factors like microhemorrhages or superficial siderosis already present on the brain MRI. Those are things that we look at for these bleeding and swelling side effects. So if you already have too many of those, then we would be concerned about making things worse. And then there are a variety of others. I won't read all these off to you, but we did see that there were a variety of reasons that people did not get, were not eligible for therapy. These are the characteristics of the patients that were treated in the, or that were evaluated in the Alzheimer Therapeutics Program, broken down by those who were found to be ineligible compared to those who were found to be eligible. And you can see a few things here. The people who were ineligible were slightly older. The sex distribution across the two groups was not different. And looking at race and ethnicity, the vast majority of patients evaluated in the first year were non-Hispanic white individuals, but there was no difference between the two groups of ineligible versus eligible based on race or ethnicity. Also looking at who is providing the insurance for these, most of our patients have Medicare, though some have non-Medicare plans. It didn't matter which type of insurance you had as to whether you were found to be eligible or ineligible. However, the referral source, which is who provided the referral, was different, and those who were referred by a cognitive specialist that specializes in Alzheimer's disease were much more likely to be found to be eligible. This is probably due to the fact that there's some pre-screening happening by the cognitive specialists who know a lot more about these medications and know who would be eligible versus who would not, and they're only referring those that they know who would be eligible, whereas a non-specialist may not be able to make that distinction as much and would rely on the ATP to help make that decision. There is a gene called ApoE that's a risk factor for developing the ARIA side effects, and there's a particular version of that gene that increases the risk. That's the E4 allele, and depending on how many copies you have, the risk goes up. So if you have 0, there's less risk. 1 copy is a little bit more risk, and 2 is the highest risk. And there was no difference in number of patients with the different versions of that ApoE gene between the eligible and ineligible groups. So that means that we weren't taking that into consideration to determine whether or not people were eligible or not. It was, a variety of other factors. Some other things that we found comparing the ineligible and eligible groups is that on measures of function and cognitive abilities, there were some differences. This FAQ, which is the Functional Activities Questionnaire, is a measure of functional status. A higher score means less function, functional independence. And you can see that the ineligible group had a higher score on average than those who were found to be eligible. Looking at these two cognitive test scores that are given, they're usually about a page long of test questions to test thinking and memory. A higher score is better for both of these. And you can see that the eligible patients had a higher score in both instances. And this is kind of a reflection of the requirements that patients have mild cognitive impairment or mild dementia to be eligible. Looking at another type of metric called the Quick Dementia Rating System, which is another cognitive and functional measure, you can see that the cognitive aspects as well as the behavioral aspects, there were significantly more difficulties with cognition and behavioral symptoms in patients who were ineligible compared to the eligible patients. And this is also reflected in the total score. This again kind of goes along with how patients have to meet certain requirements in order to be considered eligible based on their cognitive function. Looking at the side effects for infusion-related reactions, out of all the patients that were received at least one treatment, about 37% experienced an infusion-related reaction. There are different grades of these. In general, grade 1 is quite mild, typically doesn't require any medicines, very transient. Grade 2 is lasting for less than 24 hours, but may need some medication treatment, such as acetaminophen or medication to help with nausea. Grade 3 is more significant, usually lasts for more than 24 hours, may require more advanced treatment, including evaluation in the emergency department. This is, again, the reference for what was done in the trial, what was seen in the trials, and you can see that our rate is a little bit higher than either of those reported in the trials. This may be because we implemented a phone screen after the infusions to ask people not only during the infusions but afterward about if they'd experienced any side effects. If people had mild side effects like chills, they may not otherwise report that, but we had called and asked them specifically about it. And then looking at ARIA, which is the big side effect of concern here, we have the results from the Mass General Brigham Alzheimer Therapeutics here, as well as what was reported in the literature and the clinical trials here. Particularly this column on the left is of most interest because lecanemab is what most of the patients received in this program in the first year. Looking at the overall rate of ARIA, there were about 26% of patients who had any ARIA discovered at all. Breaking it down by the subtypes, it was about 13% that had ARIA-E and 23% that had ARIA-H. The rates overall for ARIA in the clinical trial, you can see that 21.5 was what was reported for lecanemab. Ours is pretty close to that, maybe a little bit higher. The ARIA-E rate is quite close, and the ARIA-H rate is a little bit higher in our cohort as well. That may be because we're using a more sensitive MRI than was used in the trial, so we're able to see these small areas of bleeding a little bit more detailed. Looking at patients who had any symptoms, there were about 6.7% of patients, 20 patients overall, that had any symptoms related to ARIA, so it's a fairly small percentage out of the whole group. For those who had serious ARIA, which required treatment with steroids and or hospitalization, it was quite small. Both of them were 1%. We have the breakdown here of based off of these different versions of the ApoE gene. I won't go through each of these numbers in detail, but the trend kind of follows where if you have 0 copies, there's less risk, 1 copy, there's a little bit more, and 2 copies, there's even more risk, as was seen in the clinical trials. These were the symptoms that the 20 patients had, and you can see that half of them were headache, and then a whole variety of other neurological symptoms, but headache was most common. So overall, the conclusions from this initial look at our program is that a majority of patients were found to be eligible, about 66% or 2/3. This is useful to think about because we want to strike a good balance. If it was 100% were eligible, then that would probably mean that we were too strict in letting people in, and we may have excluded people who would otherwise be eligible. If it was much lower, like 2% or something, we'd be wasting a lot of time seeing patients in clinic who would not be eligible. So I think 2/3 is probably a good balance. We also saw that the patients who were found to be ineligible were kind of consistent with what we would expect based off of the criteria, they had more cognitive and functional impairments than the eligible patients. And looking at the side effects, we had a slightly higher rate of infusion-related reactions in our cohort, but the ARIA rates were overall pretty similar. And we had fairly low numbers of serious ARIA, which is good. And we're thankful that we've been able to take care of patients and provide this service without a lot of serious outcomes. In terms of what we have planned for the future, we're expanding this analysis to the second year of the program to get a better, more comprehensive look at what has happened, where we've been able to follow patients over a longer period of time. We're interested in looking at the functional and cognitive changes over time while on treatment. This is challenging because this is no longer a clinical trial. We don't have a placebo group, but we're using some innovative statistical methods to try to identify untreated historical control groups that will allow us to have as a comparison to understand in the real world, not in a clinical trial, what impact this is having on cognition and functional status. And in a longer term vision, it would be great if we were able to identify predictive and clinical or imaging markers to identify ARIA. Currently, we have to rely on these periodic MRI scans. If we had something like a blood test, it would be a whole lot easier to monitor. So with that, I will acknowledge the large team that's involved in this across the Mass General Brigham system. We have physicians, physician assistants, nurse practitioners, nurses, clinical coordinators, and researchers who all participate in this effort in taking care of our patients and also helping to analyze these data so that we can learn about this program. I also received some funding from the Massachusetts Alzheimer's Disease Research Center, which is an NIH-funded Alzheimer's Research Center. Thank you for your attention. So now we'll move into a time of Q&A. We do have some previously submitted questions, but we're also happy to take questions from the audience as well. I think they're getting another one.
Here we go. We got a fresh one. There you go. Sorry about that. Thank you.
Yeah, but I was trying to find my words. Sorry. It was in regards you were saying about the dissection of the brain, and which is it from? I mean, I donated to the BU brain donation. Like, who do we get in touch with to donate the brain? Because if I want to donate my brain, I already do the BU anatomical study, so that's my purpose. But also, I want to know if you guys are studying someone's brain for do I donate it to the McCourt Foundation and say they'll find who they're going to give it to? Does that kind of make sense?
Yeah, I understand. Maybe
Long day for me, sorry.
There are several programs for brain donation. I think probably the most prominent will be the Massachusetts Alzheimer's Disease Research Center. So patients with cognitive impairment who are treated at that center, and they are asked to donate a brain. But for the program that I am following, we take in especially brains with a cerebral amyloid angiopathy, and we're starting off a program for arterial sclerosis as well. So it depends a little bit, what the clinical diagnosis is, what is the pathology. If you donate it to BU, they have a big program actually for brain injury. So it depends.
Okay, the whole anatomical donation part is like the brain part is very specific. I know BU has a specific one for the brain donation, but it has, I don't know, is it to a specific program, but you may not know that.
Yeah, so I don't know the specifics for BU, but if you intend to donate from an anatomical study, it's probably unlikely that it's directly linked also to a, pathological study aimed at a specific disease. So you should probably talk to Dan and ask whether that's the case. Yeah, no.
I'll also say that some anatomical gift programs are more for like medical students to study anatomy, so it may be more for education and research. So it may be useful to kind of think about,
I know part of it is, and I just wanted to ask, like, who do I say donate to this one instead of that one? That's what I was asking. All right.
What's the difference between cognitive and behavioral?
Excuse me, is it cognitive and?
behavior.
Behavior.
The behavior.
Oh. Yeah, well, that's a good question.
Yep.
So, well, cognitive impairment, when we talk about cognitive impairment and dementia, we specifically look at 5 domains. So we look at memory, processing speed, executive function, visual spatial, orientation. So that's more what I guess most of us refer to when we talk about cognitive, and behavior is much broader and considers, everyday life interactions and everything else, I would say. Or do you have maybe a better answer?
Yeah, so, cognitive and behavioral functions are related to each other, and you might think about cognition as what's happening inside the brain. So, if you're having a memory, you're sort of like thinking in your head about that memory. It's not something that anyone else could know about. It's just something happening inside your brain. Or if you could even think about, like, what would I do if I were going to get up and leave this room? You could say, well, first I would push my chair back, and then I would stand up, and then I would turn around, and then I would walk toward the door, and then, without even knowing that you're thinking that. No, like, none of us would know that you're thinking that. That's cognition. Behavior is sort of the outward manifestation of what's happening inside the brain. And that comes through things like actions or speaking. And those types of behaviors can become disordered just in the way that cognitive function can become disordered. So with Alzheimer's disease, memory is a particular problem, and people have trouble remembering, especially things that happened recently. That would be kind of a cognitive issue. But there are also things that can happen in a behavioral way in Alzheimer's disease as well as other types of dementia. So for example, sometimes people can be much more easily frustrated, and they're like prone to yell at their loved ones. And this is, out of character for them. And that is because the parts of their brain that help to regulate emotions and help to know what's socially appropriate and inappropriate is not working well. So there's sort of this expression, through, verbal things that they're saying, as well as maybe actions like throwing things or hitting, that may be very out of character behaviors for them, but happen as kind of an expression of the changes that are happening inside the brain. So hopefully that helps to clarify a little bit. We also have some questions that were submitted earlier. One is, how does trauma affect the impacts of these diseases?
Yeah, so I think I've mentioned already that trauma is actually one of the risk factors for dementia and potentially even for Alzheimer's disease, although maybe in an unrelated way. And it's interesting because studies, for example, conducted at BU, they showed that some of the pathology, so what we see inside of the brain after autopsy, some of the proteins that we find in Alzheimer's disease, and we also find in traumatic brain injury, although the distribution is different, but that kind of creates a direct link between the two.
Measured by the removal of amyloid
Yes, so for these anti-amyloid drugs, one of the things that we look at is the removal of amyloid from the brain. And we can use a type of brain scan called an amyloid PET scan. So especially if people have an amyloid PET scan that tells us how much amyloid there is in the brain before getting treated, then at a certain time after treatment, we can look again with a PET scan and see, has that amyloid decreased? And there are certain ways that we can determine, how much is there through, measurements with numbers. We can kind of compare those numbers over the course of treatment. And there is kind of a point where it becomes, a negative scan where we can say that all of the amyloid that we can see in the scan has been removed.
Thank you. That said, is that diminished concentration of amyloid reflected in the activity of the patient? Because there are papers that say that the removal of the amyloid does not change the behavior of the patient.
Right, so, we know from the clinical trials that these drugs do remove the amyloid from the brain, and that slows the cognitive decline overall, but it doesn't stop it and it doesn't reverse it. So there is still a continued decline of these, cognitive and functional measures in patients. Perhaps some of that is because, as I showed with the amyloid cascade hypothesis, how there are many processes that happen in the brain. The amyloid is kind of happening at the top of that, but there are many after effects of the amyloid. And when we use these drugs, we're removing the amyloid, but it's not impacting the other aspects of that cascade that are already happening.
Thank you. The second question is, you mentioned the elderly being very affected by senility, all of this. A very common affection on the senior population is chronic lymphocytic leukemia, which has hematological problems. Do they preclude the use of this therapy? Because we're talking of something that affects many ages in the senior, 65%.
It depends a little bit on...
The parameters on coagulation issues, a certain level, BT, BTG, whatever,
Yes,
the
so...
ones that we preclude.
Yeah, so for certain blood disorders like chronic lymphocytic leukemia, there can be effects on the blood cells and other aspects of the blood like clotting, and that has to be taken into consideration when thinking about the safety of using these medicines. So if someone had problems with forming the blood clots in case of an injury to the blood vessels, then we would expect that they would be more prone to bleed and may have more serious side effects related to these medicines. I would say that it's generally, a case-by-case basis, looking at an individual patient and what their overall medical profile is like, what their labs are like, to try to make decisions about whether or not a specific person can be treated. But it is important to take into consideration, all those things about, what's happening in the blood, and if there is an increased risk for bleeding, that might make it too dangerous for people to take those medicines. We have a question.
Hello. I have a question. Every year I come here and I'm waiting and waiting to hear we have found the cure for Alzheimer's. I'm wondering where you feel we are on that journey. And also recently I've been reading about lithium, that they've been doing studies on lithium in mice, and it has been successful in removing some amyloid and tau. And it seems like most of the research is on removing the amyloid or tau. Is there any other type of Alzheimer's research that's going on simultaneously to that? Thank you.
Sure. I think one line of research is the one also related to the vasculature, for example. And although we are very far behind in that sense. So we don't have, absolutely don't have disease-modifying therapies in that direction. There are some hints of research, at least on potential ways of improving brain clearance. For instance, through looking at pulsations, so which may increase the activity of the vessels and therefore brain clearance, but we're definitely not there yet. As for lithium, I think that's also very early to say, as the study has only been done, as far as I know, at least in mice, not in animal models and not in humans. So I'm not sure if I'm missing something I haven't seen, but
There are many different drugs that are being considered and tried to treat Alzheimer's disease. Certainly the amyloid targeting drugs, like we talked about, are the most far along, and some of them are in clinic, as we discussed. There are drugs that are directed toward treating tau, which is the other protein that accumulates. Those are all still in clinical trials, but that's something that is another strategy that may be useful to treat Alzheimer's disease. And it's possible, if those tau treatments work, potentially even combining the amyloid and the tau treatments might be an even stronger way to treat Alzheimer's disease, because it would be kind of hitting both of those aspects. There are inflammatory changes that happen in the brain in response to the amyloid and the tau being there, and the neuronal death. So targeting neuroinflammation, such as even with medications similar to what were discussed in the MS talks, are potentially useful therapies. And then there are many other treatments, including potentially lithium, which of course, lithium orotate is the particular substance that was studied. That was, as you mentioned, in mouse models of Alzheimer's disease. We certainly need more studies in humans to know if it's safe and effective for treating Alzheimer's disease. So no cure yet, but hopefully at some point in the future. We have a question over here. While you're moving over there, there's another question from online. When is it early signs of Alzheimer's versus acceptable forgetfulness? So this is kind of asking about these early symptoms of memory loss that are seen in Alzheimer's disease. How do you distinguish between those changes as well as kind of the normal aging process where people may be a little bit more forgetful? And it can be difficult to know exactly what is happening when people have some forgetfulness. There certainly is some degree of forgetfulness that people have in general, and especially as people get older, their cognitive function changes. And it can be difficult at the very beginning stages of the Alzheimer's disease process to distinguish those two things, because Alzheimer's is a very slow process and it starts very subtly. I would say that if you are concerned about your thinking and memory, you should mention it to your doctor. And if they feel that it's appropriate, you could perhaps have some additional testing to try to understand that. There are some more detailed cognitive tests that can be done that are like 2 to 3 hour long tests called neuropsychological evaluations. And those allow for kind of a very deep look into a person's cognitive performance. And those tests allow us to compare an individual's performance with what is generally known about people in their age range. So we're able to kind of account for this cognitive changes that happen with aging. And doing that type of test can really help us see, is this person performing cognitively as expected for age, or is there something else that's making it more difficult for them? So that's one way to tell, but I would recommend talking to your doctor if you have questions or concerns about your memory. Do we have another?
My question was, one was the chemical that's in the drug. What is it doing and what chemical is it? Because when it goes through the blood system, I'm sure that it's going through the blood system to the brain. What's the reaction that it's that chemical that's in that drug? I'm interested in what chemical is that. And the other thing is when you do the follow-up, are you looking at the people that was in the program and that they got out of it? And if the tau did go away, did it come back?
Yeah, so the chemical that's in it is an antibody. So it's a protein that is directed against the amyloid protein. And it's similar to the other antibodies that people have in their blood that help fight off infections. So it's not like a chemical substance in the traditional way that we think about them. It's an antibody that is, it's given to patients through the IV, but it is, an antibody similar to the antibodies that everybody has in their body. It's just that that one is directed specifically to bind to the amyloid and remove it. In terms of the follow-ups that we're doing for patients, we are, following their cognitive function, their functional status over time in clinic, and we're also, after people reach kind of the year or 18-month mark on therapy, we are getting the amyloid PET scans to try to look and see how effective these medicines are, and also, trying to make decisions about, does this person need longer on therapy, or is it okay to switch to a more maintenance type therapy? That's something that is relatively new, which we didn't have experience with in the first year of the program, but there's now FDA approval for what's called maintenance lecanemab treatment, which is where people have cleared the amyloid or have finished their 18 months of treatment, and now they're going to get sort of a reduced dose, but a continued dose of the lecanemab to try to prevent the amyloid from reaccumulating. So that's another thing that is kind of new and developing in this realm of treatment. And we're just now starting to have patients who have completed their initial therapy move on to that more maintenance therapy.
Okay, there was another question.
Yes, I have a question pertaining to the clinical trial. You mentioned two therapeutics, lecanemab and donanemab. Is there any determining factor as to what the patient receives?
It's a clinical program. It's not a clinical trial, actually. So it's being used clinically. There's no control group for this, but we basically allow patients to choose which medicine they want to take. There are some differences between them. One of the key ones is that lecanemab is given every 2 weeks, and donanemab is given every 4 weeks. So it's a bit more convenient, especially for people who live further away, to do the every 4-week dosing. But there are other reasons that people may want to take the lecanemab. We have more experience with it because it came out sooner or earlier, so we've had a longer time of treating people on it. There are kind of subtle considerations about what particular type of amyloid each of the antibodies target, which is a little bit different. And lecanemab has the FDA approval now for this maintenance dosing to try to prevent amyloid reaccumulation, whereas donanemab does not have that approval at this time. So that's another consideration for what medications might be appropriate for an individual person. But those discussions are had with each individual patient in clinic to try to help them make decisions on what works best for their situation. All right, and then there were a couple of questions about preventative measures to avoid Alzheimer's. I know you mentioned that a lot in your talk, but maybe you want to summarize.
Yeah, maybe to summarize that, and there is also a figure I believe that I forgot to mention during the talk, which is like 45% of the risk can actually be mitigated through intervention. So there is really a lot that every single patient, every single person can do to prevent getting dementia and even Alzheimer's disease. But if we look at early life, the first measure would be education. So that seems to be a protective factor against dementia. Then, as I was mentioned, during midlife, we had all the cardiovascular, or most of the cardiovascular risk factors, so hypertension, elevated LDL, cholesterol. So those need to be kept in check, but also diabetes, preventing diabetes and also treating it is beneficial. We should all move as much as possible. There is really also a relationship between how much we exercise and how intensely we exercise and the effect on the later life dementia. So definitely moving is beneficial, and then sleeping well, even though the evidence is not that robust yet, treating depression if possible, and also keeping a normal weight is helpful. And social contact, I think that's maybe my favorite risk factor, like avoiding, to avoid social isolation, which we saw also during the pandemic, can be detrimental. So. And hearing loss, excuse me, hearing loss, I really care about that. Most people really don't know how detrimental hearing loss can be. So treating it and using hearing aids can be very effective prevention strategy against dementia.
There are a couple more questions that were previously submitted. One is, can the new breakthrough cure for Huntington's disease also help with those with cognitive impairment from Parkinson's and dementia? I think what this question is referring to is that there's a new treatment with gene therapy for Huntington's disease, which is kind of a rare movement disorder. And Parkinson's is another type of movement disorder. They both have dysregulated movements. The treatment for Huntington's disease that involves gene therapy is a very specific treatment for that gene that is mutated in Huntington's disease. And I don't think it would necessarily have an impact on other conditions like Parkinson's. So it would need, for Parkinson's, there would need to be other more specific types of treatments. Another question is, what are some ways to help one with Alzheimer's to engage with people, projects, community games, etc., whose default activity is sleep? So this is, certainly a relevant question, especially given, the need for social engagement and cognitive stimulation. It can be challenging because patients with Alzheimer's disease have the potential to have a change in their motivation. This would be like one of the behavioral problems that can happen where they feel less motivated to do things. That can be due to changes in the brain directly, or it can also be due to other factors. For example, patients with Alzheimer's disease may have trouble engaging in conversations, so they kind of feel lost and don't really know how to say or what to say. It can make them more withdrawn. Every patient is a little bit different, but in general, trying to think about, what it is that person likes and wants to do, and situations that would make them uncomfortable, and trying to avoid those. And so, for example, having a large gathering in a large crowd where everybody's talking and there's a lot of noise may be very overwhelming for a patient with Alzheimer's. But if you're able to have those social interactions be, one or two close family or friends who kind of understand the condition that they have and can sort of accommodate that in their conversation and really, make an effort to draw them in, might be more effective. In terms of, cognitive activities, people will have different abilities as to what they can do easily. So you would sort of want to choose activities that are appropriate for what a patient can do and likes to do. You don't want to make things so hard that it's not enjoyable, but if there was some activity that kind of exercises the mind that they did enjoy, that they can still do, then that may be more appropriate to do. All right, any final questions from the room? All right, well, with that, I think we can end the session, but thank you all for joining.
Thank you.